Welcome to today's Vermont-Oxford Network Grand Rounds, Evidence to Practice, Eat, Sleep, Console. I'm Dr. Danielle Arrett, the Aspo Yomaru Green and Gold Professor of Global Health and Pediatrics at the University of Vermont, Chief Medical Officer and Director of Global Health at Vermont-Oxford Network. I'm pleased to be joined by Professor Roger Saul, who's the H. Wallace Professor of Neonatology at UVM, the Coordinating Editor of Cochrane Neonatal, and the Director of the Institute of Evidence-Based Practice for Vermont-Oxford Network. We have two wonderful discussants today, both hailing from Larner College of Medicine, University of Vermont, Dr. Leslie Young, who is an Associate Professor of Pediatrics, and Dr. Adrian Paul, who is currently an Assistant Professor of Pediatrics. Today's session is sponsored by Vermont-Oxford Network and our Institute for Evidence-Based Practice. Here are our disclosures as they relate to our leadership roles and funding, and we don't have any conflicts of interest to disclose. So everyone joining in today, it looks like 500 plus, counting in the participants, recognizes the challenge that our families, our healthcare teams, hospitals, and systems have in appropriately caring for infants with neonatal abstinence syndrome or neonatal opiate withdrawal syndrome. We're excited that we have today's session to talk about the evidence, our opportunities for learn, and where the evidence is focusing us. So we have an hour of wonderful discussion, and we're excited to be focusing in on this today. We really hope that this is a robust conversation and dialogue. We have two different options for the audience to join in the participation. One is to use the chat feature in Zoom and to choose comments or questions selected to everyone. And we'll also have several polls that will pop up using the Poll Everywhere platform. We hope that you can use one of the various options for Poll Everywhere so that we can see our answers joining in with the whole group. We apologize, those that are in the chat won't be added in. So we have three different ways to use the Poll Everywhere app. The first is to use a web platform or a internet engine. You can use the QR code that you see or pollev.com/VT-Oxford. The second, there's an app. And then the third is to send a text on a mobile device. So we'll give this a try. And the first is to see what types of practice environments our audience is joining from today. So please answer for yourself, whether you practice in a hospital with a level 3 or 4 NICU, a hospital with a level 2 NICU, a community hospital that doesn't have an ICU for neonates on site, or a different type of setting. And it looks like so far about 80% of our participants here are at a hospital with the level 3 and 4, but really excited to see the diversity in answers, those representing sites with level 2s or community hospitals without NICUs and some other settings. I know we have some teams and providers joining us from all sorts of different places in which we care for mothers and their infants. Great. Well, we'll have some more polls coming up later. The next one is whether you have a written guideline that addresses the management of infants with opiate withdrawal. So recognizing that we have a lot of NICU sites, it looks like the vast majority do have a written guideline. Those that are uncertain or are answering no, hopefully we'll have some ideas that come from today's session about what might be some next steps on that pathway. And in speaking about the evidence that might inform those guidelines, I'd like it to turn it over to Professor Roger Saul to share with us the evidence to practice on the caring for neonates with opiate withdrawal. Over to you, Roger.
Thanks, Danielle. I'd like to take the first part of this seminar to just briefly talk about the evidence regarding the care for newborns with opioid withdrawal syndrome. As any of you who are tuning in the United States know, there's been a surge of opioid use in the United States. From 1999 to 2009, there was a quadrupling of opioid pain reliever prescriptions and sales nationwide. Not surprisingly, this led to a huge increase in the number of mothers who were on opioids at the time of delivery. Here, looking at the national prevalence of opioid use disorder for 1,000 delivery hospitalizations, we see a nearly fourfold rise in mothers with opioid-exposed newborns delivered between 1999 and 2014. These infants need careful follow-up and assessment. Since the 1970s, there have been several scoring systems that were developed to guide the diagnosis and treatment of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. But there is no one agreed upon scoring tool. Perhaps the most frequently used tool is the Finnegan Neonatal Abstinence Scoring System, developed in the early 1970s by Dr. Loretta Finnegan. It is now a widely used tool for assessing and managing neonatal opioid withdrawal symptom, helping healthcare professionals quantify the severity of withdrawal symptoms and guide treatment decisions. The tool is an assessment of 21 signs and symptoms related to opioid exposure. Infants are assessed on a point system where each sign and symptom are weighted with corresponding values. For many centers, the threshold to begin pharmacologic treatment is either 3 consecutive scores of 8 or more, or 2 consecutive scores of 12 or more. There are clear benefits to introducing a scoring system. First and foremost, it allows for standardized assessment of these infants. The score can help guide treatment and facilitates communication both between staff and between staff and families regarding the infant's status. It can be used to track progress and, in many centers, is used to help identify infants who need pharmacological treatment. But there are also real concerns. There are the complexity and length of the scoring itself, the subjectivity and poor inter-rater reliability of some of the outcomes, a lack of validation, and uncertain clinical relevance. Disruption of the infant happens to do the scoring, and the score may overestimate the signs of withdrawal. So let's turn our attention to the two very basic approaches to management, either non-pharmacological care of the infant withdrawal or the pharmacological care of infant with withdrawal. To start, there is a Cochrane review conducted by Adrian Paul, who you'll be hearing from later, regarding non-pharmacological management of opioid withdrawal in newborns. Non-pharmacological management seems like it might be a very simple issue, but in fact, it involves fairly complex evaluation of at least 3 domains. First and foremost, there's the infant's neurobehavioral function. You need to evaluate and facilitate regulation in the domains of state control or attention, autonomic regulation, motor or muscle tone, and sensory processing. For each individual infant, you need to determine what triggers signs of opioid withdrawal symptoms. For the mother, you need to evaluate her psychological functioning and her ability to interpret and respond appropriately to the infant's cues. And lastly, the provider and the institution need to consider their role. We need to be able to create facilities that can care for the mother-infant dyad in an appropriate way. We need to alter the environment regarding sound and other stimulation that can help facilitate the infant's management. In Dr. Paul's Cochrane review, she wanted to evaluate the safety and efficacy of non-pharmacological treatment of infants at risk for or having symptoms consistent with opioid withdrawal. And she took a look at 2 populations. She took a look at infants at risk for or having early symptoms consistent with opioid withdrawal, and another population of infants receiving pharmacological treatment for symptoms consistent with opioid withdrawal, and asked what was the value of non-pharmacological treatment. They included studies that compared either single or bundled non-pharmacological interventions to no non-pharmacological treatment or different single or bundled non-pharmacological interventions. They assessed these interventions independently and in combination based on sufficient similarity in populations, intervention, and comparison groups. And they characterized the non-pharmacological interventions as either those that modified the environmental stimulation, those that altered feeding practices, and those that supported the mother-infant dyad. I'm afraid to say there's a paucity of trials that address these issues. Only 6 trials involving a scant 353 infants. In fact, no trials evaluated situations where the infant was receiving opioid treatment for symptoms consistent with opioid withdrawal. Of the 6 randomized controlled trials that addressed the infant prior to considering instituting pharmacological treatment, 4 studies assessed the modifying of environmental stimulation in the form of either a mechanical rocking bed, prone positioning, a non-oscillating water bed, or a low stimulation nursery. 1 study looked at feeding practices, comparing higher and lower caloric densities formula, and 1 study assessed the support of the maternal infant dyad. Unfortunately, regarding our primary outcomes of length of hospitalization or pharmacological treatment, we see few, if any, differences. There was no effect on length of hospitalization from the 1 study that modified environmental stimulation and from the 1 study that supported the mother-infant dyad. Similarly, none of these 3 non-pharmacological approaches could be proven to alter the need for pharmacological treatment. From the scant evidence, Dr. Paul and colleagues claimed that they were uncertain whether non-pharmacological care for opioid withdrawal in newborns affects important clinical outcomes. And although caregivers should be encouraged to optimize non-pharmacological care, the authors cited the need for larger, well-designed studies to determine the effects of non-pharmacological care for opioid withdrawal. Regarding pharmacological care, there's perhaps a little bit more evidence. For infants with severe NOWs, use of a medication in addition to non-pharmacological measures may be necessary to improve clinical signs of withdrawal and minimize complications. Ideally, pharmacotherapy minimizes these signs of withdrawal, and then, as the infant is weaned off medication, pharmacological therapy should be considered only for severe opioid withdrawal that is refractory to non-pharmacologic intervention. Multiple studies, including randomized controlled trials, have been conducted to find the optimal medication. Unfortunately, although pharmacological management does affect and improve the symptoms of withdrawal, it does lead to a longer overall length of stay. Although opioids remain the preferred mainstay pharmacological agent in the treatment of opioid withdrawal syndrome, there is no clear consensus on the choice of opioids. In a 2021 Cochrane review evaluating pharmacological treatments, found that opioids was associated with reduced treatment failure compared to other drugs, including phenobarbital, diazepam, or chlorpromazine. Morphine and methadone remain the most common first-line medications and appear to be similarly safe and effective. And morphine and methadone have similar rates of treatment failure, initiation of breast or expressed human milk feeding, and adverse events. But let's take a look at reevaluating this entire process, which really begins with our reliance on scoring the infant's withdrawal. As noted earlier, there are questions about the use of the Finnegan neonatal abstinence scoring syndrome. Many of the symptoms that are measured are not exclusive to NOWs. For example, hyperactive moral reflex, yawning, nasal stuffiness, seizing, etc. And in fact, these signs can add up to 6 points just on their own. That's concerning, since the threshold for treatment in many facilities is a score of 8. Further, an infant score is based on 21 relatively subjective items, which leads to variability between scorers. While the Finnegan neonatal abstinence scoring tool has been a catalyst in improving care, other newer methods may more accurately and effectively address the need of infants with NOWs. Shifting from a score-based assessment tool to a function-based tool, from medication management to primarily non-pharmacological care, and from physician-led care to family-focused care management has now been demonstrated to improve outcomes for infants with NOWs. Eat, Sleep, Console is such an approach. Eat, Sleep, Console is an alternative approach to NOWs assessment and emphasizes non-pharmacological care as the first line of treatment, starting with the creation of a low-stimulation environment. ESC emphasizes parental involvement in determining care and treatment plans, which results in increased support of the mother-infant dyad. Compared to the lengthy 21-item list of the Finnegan tool, which requires disturbing the infant, Eat, Sleep, Console focuses on 3 observations of whether the infant can eat, whether the infant can sleep, and can the infant be consoled. If these criteria are met, we don't need pharmacologic intervention. If not, in fact, we need to reprioritize our use of non-pharmacological care. But it's not so straightforward of how we move from our tradition of relying on Finnegan scoring to the Eat, Sleep, Console approach. We don't want to throw out the baby with the bathwater. And we're thrilled to have 2 experts, both from the trials perspective and from the evidence-based practice perspective, to share with us their insights into this revolutionary approach. Danielle?
Thank you so much, Dr. Saul, for that wonderful evidence review and a bit of a historical context. I'm so pleased to now welcome Dr. Leslie Young and Dr. Adrienne Paul to share their recent and ongoing exciting work advancing care for neonates with opiate withdrawal syndrome. First up, I'd like to welcome Dr. Young. Over to you.
Thank you, Danielle. Before discussing the evidence to support the ESC care approach, I'd like to start by providing some context for the trial that was conducted and help lay the foundation for the why behind this work and the work that those listening today might be considering. The Advancing Clinical Trials in Neonatal Opioid Withdrawal, or ACT-NOW collaborative, was designed to inform a standard approach to caring for infants with NOWs through large, multi-center studies intentionally developed to address knowledge gaps in the field, while leveraging 2 established networks uniquely poised to address this crisis quickly, and clinician scientists in highly affected areas who were motivated to develop evidence to improve care. Our initial step in our work was to understand the clinical landscape that we would be conducting these trials against. We conducted an observational study across 30 participating sites, including 1,377 infants, and we found that a substantial degree of site-level variation exists across all domains of care, and that this variation was more than any one of us would have anticipated, given our practices at our own care settings. We found from this work, much like Roger has concluded, that the area where we could have the most substantial impact in our studies moving forward was starting at the beginning in our approach to assessing infants with NOWs. In order to provide infants with the best support and care during their admission, we really needed to have a better understanding of how to assess them. And we knew we were answering the right question. The average hospital stay for infants with NOWs from our work we found was 12 days. For infants who receive opioid treatment, however, the average stay is approximately 3 weeks longer than for infants who did not, 24 days versus 4. And from our work, we found a substantial degree of variation across our sites in the proportion of infants who receive pharmacologic treatment. Here I show a box and whisker plot where each dot represents a site, and you can see its position along the x-axis represents the proportion of infants treated pharmacologically at those sites. Here, our sites range from 7% of infants receiving pharmacologic treatment to 100% of infants receiving pharmacologic treatment, really calling into question, is there better way to assess NOW severity and identify infants who should receive pharmacologic treatment? Roger's done a great job discussing the Finnegan neonatal abstinence scoring tool and outlining its use over the last several decades. However, many clinicians do believe it overestimates the need for medication and believe that an alternative is needed for our assessment of these infants. And families find these inconsistencies frustrating at best, and they can contribute to a degree of mistreatment in the medical system and further compromise engagement of families. The ESC care approach is one alternative that's been proposed and the one that we'll be discussing most today. This is a function-based assessment of now severity that was first proposed by Matt Grossman and colleagues out of Yale as a novel and simplified approach to the assessment of these infants, placing an emphasis on the functional components of withdrawal. Simply, can an infant eat, sleep, and be consoled? There were many that were quick to begin replacing the Finnegan with ESC and their assessment approach for these infants. But it's important to highlight that the work Matt Grossman and colleagues published didn't just include this novel approach to the assessment of now severity. It was, in fact, quality improvement work that was extensive and stretched over the course of 8 years and showed a reduction, yes, in the receipt of pharmacologic treatment from 98% to just under 15%, but it included the standardization of non-pharmacologic care, this novel approach to assessment, and the empowering of families in the care of their infants. So ultimately, the Eat, Sleep, Console approach isn't just this function-based assessment of now severity, but as Roger has highlighted, this approach is a comprehensive one that includes also the optimization of non-pharmacologic care and the support of families and empowerment in their care of their infants. In time, the ESC Care Tool, which is an assessment and management tool that guides care provided under the ESC Care approach, was developed by our colleagues out of Dartmouth Hitchcock Medical Center, Boston Medical Center, and in conjunction with Matt Grossman at Yale. It was developed to streamline implementation and support consistent application of the ESC approach across care settings, across providers, and across infants. The ESC Care Tool, which looks complex here, but is actually quite simple, includes an assessment component, which has definitions right there on the tool that allow for consistent communication with the family, a management component, which allows for consistent application of a care plan, and the non-pharmacologic care interventions are listed there in blue and allow for the family and the nurse to walk through what is currently in place, what may need to be reinforced further, and what may need to be added to support the infant in that moment. So the Eating, Sleep, and Consoling Care approach includes the function-based assessment of now severity, this optimization of supportive interventions, and places an emphasis on education, supporting and empowering families in the care of their infant, all guided by the use of the ESC Care Tool to allow for consistent communication and collaborative effort to support optimal care for the infant. Initial quality improvement initiatives showed promise with improvement in hospital outcomes, a reduced receipt of pharmacologic therapy, a reduction in length of stay, and an increase in parental presence. And we didn't see any increase in balancing measures or adverse events. This led some to say, why do we need to study this further? Well, evidence to support the ESC care approach was limited to local and regional quality improvement work, calling into question the generalizability and effectiveness of this approach. As we know, there's variation across our care environments in the care we provide. There's also variation in the resources we have, the care environments themselves, and our population we care for. Additionally, the potential effects of the ESC care approach on infant and family well-being and on infant neurodevelopment following discharge were largely unknown. It's hard to do this with quality improvement work and really requires a randomized controlled trial to assess these outcomes further. And there were many who were quick to want to implement ESC more broadly, but then there were many in the field who asked us to be cautious, to understand the long-term outcomes before broader implementation. But ultimately, a further why behind the work that we're looking to do was that this care approach allowed families to feel less fearful, allowed them to feel like they were genuinely part of the care team, and that their involvement in the care of their babies was critical and actually foundational to the success that they would have. And it helped families feel more like every other mom, a mom and their baby, made them feel respected and a part of the care team. So we needed to build the evidence one way or another and understand the implications of this care approach. We conducted the ESC Now randomized controlled trial, which compared the ESC care approach to usual institutional care using the Finnegan Neonatal Abstinence Scoring Tool or a modification thereof. It was conducted using a step wedge cluster randomized design with randomization occurring across 26 sites in 18 states And all eligible infants were enrolled under waiver of consent for the short-term outcomes portion of the study, while consent was obtained for long-term follow-up. Here I show a schematic of our study design. Our 26 sites were randomized into one of the 8 blocks you see there to the left, and those 8 blocks were randomized into the timing of their transition to the use of ESC. All sites began caring for infants using usual care, where they provided care using institutional care practices for all domains of care, including assessment of withdrawal severity, use of non-pharmacologic interventions, and pharmacologic treatment and discharge. Sites would subsequently transition into using the ESC care approach, where they provided care for infants using the ESC care tool for the assessment of withdrawal severity and to guide management. Non-pharmacologic interventions were optimized to the extent possible at each site, and approach to pharmacologic treatment and discharge was per the site's usual care practices. Ultimately, 1,305 infants were enrolled, 702 in the usual care periods, and 603 in the ESC periods. Here you can see the maternal and infant characteristics, maternal to the left and infant to the right. And I'll say they're balanced between the two groups, with the exception that we had a larger proportion of Hispanic moms in the usual care group and a larger proportion of moms coming from metropolitan areas in the ESC group. And this was largely due to the timing of transition of sites with larger Hispanic and metropolitan populations. For our primary outcome, we showed a reduction of 6.7 days in the time from birth until infants were medically ready for discharge between our intervention groups, with infants in the usual care group having a mean number of days of 14.9 and infants in the ESC group 8.2. For our secondary outcomes, we looked at length of hospital stay and showed a similar reduction of 6.2 days. Pharmacologic treatment was reduced by 32.5 percentage points, with 52% of infants in the usual care group receiving pharmacologic treatment, and just under 20% of infants in the ESC group. Adverse events were relatively rare across the study. The only outcome that had sufficient data to do inferential statistics was our composite safety outcome at 3 months, and we showed no difference between the two groups. In summary, when compared to usual care, the ESC care approach decreased the time until infants were medically ready for discharge and reduced the receipt of pharmacologic treatment. We concluded that the ESC care approach appears to be safe for the assessment and management of infants with NOWs through early infancy. But we wanted to continue building the evidence and answer the questions that had been raised in the field. Specific questions included, what about those infants who need pharmacologic treatment for their opioid withdrawal? Might there be a delay in initiation of treatment, causing them to be harder to capture and require higher doses or longer duration of treatment? So we looked at the infants who had been pharmacologically treated, 463 infants in total, 320 in usual care and 143 in the ESC group, and found that, yes, infants in the ESC group did receive treatment later, 22 hours later, but this did not translate into higher peak doses or into an increase in adjuvant therapy between the groups. We did, however, see a reduction in the total postnatal opioid exposure, 4.1 morphine milliequivalents per kilo less in the ESC group, and a reduction in the total number of doses received, a decrease of nearly 50 doses in the ESC group. Additionally, the duration of treatment was reduced by 6.3 days, with a similar reduction seen in the length of stay. So what about growth and feeding outcomes for infants cared for?
Apologies, everyone. We're having a technical issue. We'll get this going here in just a second.
While Andy is getting the video back up, I just wanted to call everyone's attention to please let us know if you have any questions in the chat. I see a number are coming in, and we hope that at the end of our session today, we'll have at least 10 minutes and we'll be able to discuss some of the really important questions that are coming out in the chat. So please chat them in, put it to everyone, and we'll have time with Doctors Young, Paul, and Saul to discuss those together. So keep them coming.
Danielle, while we're waiting for Andy, there were a couple of things that came up that I was curious about. We were asked, I used data on the number of mothers delivering. That's a decade old now. I did not find anything more recent, and I was particularly interested in either Adrian or Leslie, whether or not there is a more recent update of that number. I don't, from my personal sense of practice, I don't have a sense that it's gone down in any way, but I didn't know if there's a better citation or resource for that.
Yeah, I don't know that there is a much better resource, Roger. I will say we have some data that maybe gets a little closer to 2017. 2018. There's some suggestion from some sources, although I don't know that they're entirely comprehensive, that while the maternal level of use during pregnancy continues to stay relatively stable and perhaps even rise, that NOWS is going down. And I think that's actually because of how we've defined NOWS. And for some time, it had to do with need for pharmacologic treatment. And so I think it becomes a little challenging to truly say what the numbers are doing.
Good point. Andy, it looks like I see Leslie's slide up. Are we ready to run the recording again?
Let's keep going with this one, and then we'll transition as we need to.
All right, thanks so much, and sorry for the delay, guys.
Number of doses received, a decrease of nearly 50 doses in the ESC group. Additionally, the duration of treatment was reduced by 6.3 days, with a similar reduction seen in the length of stay. So what about growth and feeding outcomes for infants cared for using the ESC care approach? There was concern raised that infants may have a higher metabolic rate in the context of more withdrawal symptoms, and that they may lose more weight or have challenges with feeding or require fortified feeds. So we looked at our 1,305 infants, and we found that there was no difference between the groups in the proportion of infants who had severe weight loss, as we defined it greater than 10%, or in maximal percentage weight loss between the groups. We also did not see a difference in discharge weight. The only place we saw a difference was in the weight on day of life 3, and this is of questionable clinical significance. We saw no difference in the receipt of high-calorie formula during the hospital stay, or in the receipt of gavage feeds, or fortified formula feeds at discharge. The only place we saw a difference, and in keeping with the quality improvement work, was in breastfeeding. In all domains that we assessed, we saw an improvement in breastfeeding for the ESC group, 11 percentage point increase in breastfeeding anytime during the hospital stay, a 15.7 percentage point increase in breastfeeding at the time of discharge, and a more than doubling of exclusive breast milk at discharge with an increase of 8.4 percentage points. So what about PRN or symptom-based approach to pharmacologic treatment? As I said, PRN dosing was not part of our study. We felt that it was a completely separate intervention and should be studied as such. So our study will not speak to PRN dosing. However, I'm pleased to say there is ongoing research that's being conducted by our research group to look at symptom-based dosing through a comparative effectiveness multi-center randomized controlled trial conducted at 23 sites across 13 states using a 2-period cluster crossover design. The primary objective of this study is to compare the length of time from birth until medically ready for discharge between infants with NOWS at risk for pharmacologic treatment and managed for NOWS with either a symptom-based approach to dosing or a scheduled opioid taper. And I'm happy to say that we actually just closed enrollment on this study. So what about the long-term outcomes for these infants and families? Follow-up through 2 years of age for the consented subpopulation of infants has been completed and will further inform application of this care approach. Our outcomes include 3 prospectively identified domains, including infant well-being, family and caregiver well-being, and infant neurodevelopment and behavior. And though I cannot share results from this study, and I have to ask you to stay tuned, I can safely say that evidence generated from this study will further support your consideration of this approach. So with that, I look forward to our continued conversation, and back to you, Danielle.
Thank you so much, Dr. Young, for sharing that truly amazing body of work that you have led over the past decade and the teaser of the results that we have soon to come. I think we're all on our edge of the seats for that, but happy to hear some positive suggestions headed that way. Next up, I'd like to welcome Dr. Adrienne Paul, who has served as a faculty trainer in the ACT Now trial, as well as thought deeply about the implementation and training options. So over to you, Dr. Paul.
Thank you, Danielle. Now we will shift gears to discuss implementation and training options, exploring how we can translate this evidence into practice. Dr. Young has shown us that there is clear evidence for use of the ESC care tool. However, while the intervention is simple in concept, the transition to a new model of care can be complicated. Each of our settings is unique, and we must each determine the best approach for local implementation. This complexity was recognized early on in the editorial that accompanied the original publication of the ESC randomized controlled trial in the New England Journal. Wanda Barfield emphasized the importance of developing tools and resources to facilitate implementation across varied settings and ensure that this new model of care is broadly available for all patients. This complexity is what we will dive into next. As we move beyond the study to wider implementation and dissemination, it is important to recognize that the ESC care tool has been successfully implemented in a variety of settings. This ranges from 26 sites in 18 states for the ESC trial to small community hospitals that rarely care for infants with NOWs. Each site has encountered different challenges and successfully implemented ESC in the setting of varied resources, varied hospital and state policies, and even varied leadership engagement. A common thread is that each site has champions and is motivated for change. For the sites trained by the ESC training group, a typical approach is a train the trainer model, where teams of site champions participate in a simulation-based training and then design a local site training based on their experience. The goal is for the attendees to attain 100% inter-rater reliability in using the ESC care tool, while also gaining important tools for successful implementation. The length and form of training has varied and was adjusted to suit the needs and resources of each site, ranging from a half day to 3 days, with varying degrees of in-person, collaborative, and asynchronous work. Common training elements include pre-training efforts to lay the foundation for ESC, including a strengths and needs assessment for the site, education about NOWs, and review of the ESC care tool prior to the training. Post-training, we have found it helpful to have an ongoing forum to discuss challenges, whether that is specific difficult cases or systems issues that need further discussion. For many trainings, this has been integrated with rotating supplementary education modules. Key resources that were made available for each site include foundational educational materials and cases for assessing inter-rater reliability. To ensure fidelity, we recommend that trainers have 100% inter-rater reliability with the written cases, and bedside staff have 80% inter-rater reliability prior to using the ESC care tool clinically. One example of the Train the Trainer session is the 2-day intensive training used for sites in the Act Now ESC trial. This training incorporated live, interactive, virtual case simulations to provide each attendee the opportunity to practice using the ESC care tool in a clinical setting, as well as trauma-informed care discussions and opportunities to brainstorm anticipated challenges and solutions. It was designed to support 100% inter-rater reliability in written case completion so that the attendees would be ready to train others at their site. When thinking about if and when your site might be ready to implement the ESC care tool, there are a number of common questions that arise, and we will take a moment to discuss some of these. The most straightforward question is how to train staff. Whether it is for implementation or to maintain competency, the trainings should be customized for your site with a goal to have 80% inter-rater reliability for all staff who are using ESC. Some sites with large staff will train a core team to care for infants with NOWs, while others will train their entire staff. Some will use in-person large group sessions. Some will train one-on-one or virtually. In terms of maintaining competence, whether it is due to low numbers of infants with NOWs, a very large staff, or staff turnover, many sites put a system in place as they implement the ESC care tool. There are many options that have been used, often in combination. Many sites develop a just-in-time training package with resources for nurses and team members to refresh their understanding. Some practice ESC assessments on any newborn. Without documenting in the chart, they observe and then review the ESC care tool outside of a patient's room with another staff member to keep the assessment process familiar. Others have developed annual online competencies using written or video cases, and some have created a forum for case discussions or encouraged staff to attend external educational sessions. Another common question is, how do we prepare families before hospitalization? This question is an important part of laying the foundation for ESC. For patients and families, the journey does not start or end in the hospital, and ESC implementation is an opportunity to re-engage with prenatal, substance use disorder, and pediatric care providers, as well as community resources, to ensure there is a common understanding of the fundamental aspects of ESC. This includes the importance of planning for parental presence and rooming in, limiting excess visitors and maintaining a calm environment, promoting skin-to-skin and breastfeeding, and planning for respite by identifying support people who can stay with the baby to give parents breaks. What if you don't have an option for caregivers to room in, or parents are unable to be present? A key teaching point of the training is to optimize non-pharmacologic care for your setting and for that moment in time. If you do not have a rooming in environment, focus on optimizing the non-pharmacologic care that is feasible at that moment. Make plans to continue to optimize the setting in the future to promote parental presence, such as making the environment as inviting as possible for parents, or seeking a place for families to stay overnight. In the background, continue to advocate to make rooming in possible for all patients in the future. In the moment, if no caregiver is present, whether due to space, custody, or other issues, huddle with your team. Think outside of the box. Is there anybody else who is available to be present for the baby? Or is there anything that your team could do to facilitate parental presence, such as gas cards or parking passes? If an infant is in state custody, consider including the caseworker in the huddle to discuss who might be able to be present for the baby. One key function for a team huddle is to bring the team together and to brainstorm new ideas in the moment. What about the ICU setting? Again, it is important to remember to optimize non-pharmacologic care for your setting. Some non-pharmacologic care is more difficult to provide in the ICU setting, and some is more readily available. Some unique non-pharmacologic approaches that may be used in ICU include strategic staffing assignments or placement in the unit to provide more nursing support and minimize noise from neighboring patients or provide a private area for parents. When possible, you could involve therapy services or volunteers in the care of infants, especially if you have a cuddler program. The ICU is often intimidating for caregivers, and it is helpful to reinforce the value of the parent or caregiver being part of the care team and being present to support an infant. More broadly, it's always helpful to ask whether an infant truly needs ICU level of care or whether another setting may also be considered appropriate. Some infants who are in the ICU have other reasons that could cause eating, sleeping, or consoling difficulties. When evaluating these infants, consider whether the symptoms you are seeing are due to NOWS or due to a non-NOWS etiology, such as prematurity or hypoglycemia. Better understanding the etiology of symptoms may affect your decisions about care, in particular decisions about pharmacologic treatment. As you can see from these common questions, there are often multiple potential solutions to the questions that arise. When implementing ESC, it is essential to collaborate locally and determine the best approach for your site. Identifying a local champion or team of champions to design implementation and support the care team after implementation is an important first step. Once this team is in place, they can review the core tenets of ESC and customize implementation for the site, brainstorming strategies for local implementation. The message I hope you all take away from this presentation is that the ESC care tool can be successfully implemented in a variety of settings as long as you have an invested team prepared to optimize care in your setting. As we have discussed, there are multiple pathways forward in training. There are also important upcoming opportunities. Video and written training materials from the trial will be made publicly available once the study closes. Additionally, the ESC faculty are partnering with the Vermont Oxford Network to explore ways to support training. As a first step, we are excited to be partnering with the Hospital Association of Kentucky on a statewide training cascade and rollout in 2025. Overall, together, we hope to make the simple and non-pharmacologic approach a treatment that is equitable and available for all. Thank you for your time, and I will turn it back over to Danielle.
Thank you so much, Dr. Paul. That was such a wonderful overview, and we are also very excited as a VON leadership team member about that first step that we're doing, partnering with the ESC faculty, as well as the Hospital Association of Kentucky and the statewide PQC on the statewide cascade and training rollout later this year, in addition to exploring new opportunities on the horizon. And although we'll get to it at the very end, we will have a survey that is often used for continuing education. So you'll be able to get the one credit hour. But in addition, for those of you tuning in today that are interested, I see the chat blowing up with interest, who would like to engage with us further. We're in the process of really trying to see what most is needed by the community and how we can fit into that landscape. So please share that interest with us at the end. And to come back to some discussion on some amazing topics that have been brought up and wonderful questions, I'd like to invite Dr. Saul, Dr. Young, and Dr. Paul to turn their videos and microphones back on. We have 4 poll questions to really, I think, get the conversation started and to get us thinking, as well as some time for some questions. So we saw at the very beginning, I think about 95% of those tuning in did have guidelines at the highest level of approaching care for infants with opiate withdrawal. So in this question, we're going to dig a little bit deeper. So knowing that most have guidelines, we'd like to know which aspects of care those guidelines are covering. So this is a little bit of a complicated question. We've listed 5 different aspects of care. Might be the assessment approach, non-pharmacologic care, pharmacologic care, feeding, including breastfeeding eligibility, and toxicology testing. So option A is if all 5 of those are covered in your guidelines. Choice B is if it's 3 or 4 of those. C is 1 or 2 of those aspects. Choice D is guidelines are not covering those 5 aspects of care. And E is the honest answer. I'm not sure, but you're going to learn after today's session. So it looks like we've got more than 100 responses. They're coming in quickly, but close to half having all 5 aspects of care, close to 40%, 3 or 4 aspects of care. I don't know if Dr. Young or Dr. Paul, any quick comments? I'm surprised that those numbers are as high as they are. I know you've seen the shift of care across, this country. Any comments on that?
I'm really pleased to see this as well, to see how many people have guidelines for all 5 of these approaches. I think especially with the emergence of ESC, it's really important that we update our guidelines as we are transitioning our care approach.
Maybe the next poll, Andy. All right, and then specifically kind of that first point, which type of assessment approach is used at your hospital? The first choice is the Finnegan Neonatal Abstinence Scoring Tool, which Roger had reviewed at the very beginning of this talk. Historically, that had been the basis. Choice B is the Eat, Sleep, Console approach. Choice C is specifically using Eat, Sleep, Console care tool within that approach. D is a bit of a combination, and E is something else. So it looks like we still have quite a few teams using Finnegan, close to 40%. And then amongst the 2 different options that relate to ESC, about 50%. I'm not sure, Dr. Paul or Dr. Young, if you want to comment the differences between B and C or thoughts on these answers as they're rolling in and dynamic and changing.
Yeah, I'm happy to. I'm pleased to see the split here with the continued use of ESC. I attempted to draw the distinction in my portion of the presentation, but I do think it's worth continuing to reiterate that not all ESC is the same. And so the ESC assessments are an important component of the ESC care approach. But the ESC care approach really is a comprehensive approach to caring for the infants. And for our study, we supported that with the ESC care tool to allow for consistent application, because consistency really is key. So happy to see the number of folks using the care tool.
So this is exactly the reason we have such seminars, is there's a variation. And there are some people who've adopted ESC. There are some who've adopted it specifically with the care tool. But there's still a third of people that are probably thinking about what they should do and should take some courage of hearing both the strength of the evidence from Leslie, the possibilities of how you implement from Adrian, and the fact that many of your colleagues have tackled this. So this is perfect. This is exactly what we like to see.
And then next up, using the Poll Everywhere platform, we'll have 2 different word clouds. So we'd like you to submit 1 or 2 words, and really either if you've already implemented or you're thinking of implementing, and there's something that's holding you up, some barriers to implementing Eat, Sleep, and Console at your institution. And I know Dr. Young and Dr. Paul have heard these and dealt with these, and Adrian, you even called out frequently asked questions, and I think there's frequently addressed barriers. Change is always hard. That looks like it was the first word up there and the biggest. Staffing, I see, is also a big question. And I think I've seen some of this come up in our chat today too. A few, questions that really seem to stick out related to the staffing and the parents. The first was really thinking about, as leaders in our units, whether that's a level 3 or 4 ICU, a level 2, a community hospital, or a birthing center, how are we best caring for families? There was a question about the nurse to patient ratio. Is this something, that we should think about as we're implementing this care tool or this care approach? Maybe, I'm not sure who wants to take that one. Adrian.
I'll certainly jump in. I think thinking about your site and what you're capable of as you're implementing ESC is really important. And one of those questions is, do you have the power to adjust your nurse to patient ratio? Do you have the power to change anything that would make the site more comfortable to parents and more inviting to parents? Another thing that we often talk about that I'm actually surprised has not come up on this word cloud is culture and the change in culture that is often part of implementing ESC. So I would encourage everybody to think about that locally as well. Do you feel like you need more staff education on trauma-informed care or exposure to lived experiences? Can you share stories that will help change your culture?
Yeah, I think that's exactly right, Adrian. Culture has always been a big one, and this really does involve buy-in at multiple different levels, which I think I see people kind of getting at here, staffing being a prime change for that. One of the things I will say, and in my experience, both at our own site at UVM, but also across the study, was the shift in the bedside nurses and the care team and their how they were drawn to caring for this population. I think it can be a very challenging population to care for, and sometimes people find it a frustrating part of their day potentially. And that shifted during the course of people's implementation. And this actually became a way of preventing burnout at the sites with staffing and to help them feel like they were really contributing in a positive way to improving the outcomes for these babies. And they saw the families lean into that relationship and that collaboration, and it became really rewarding for folks. So another side of the coin to be considering.
Obviously, that's beautiful. And I think a wonderful segue, we have one other word cloud. So you nicely kind of transition from what are some of the barriers to then what has made it successful? And how can we look at the other side of the coin and turn something that is a challenge into something that is a strength for our unit? So this is the last poll. And for those who have already implemented and really seeing successes, we're trying to bolster encouragement and learn from each other, even in this 800 participant webinar. We'd love to hear one or two words about what teams or team members felt like was critical to success of implementing this.
While this word cloud is forming up, if I can just throw us back to the last one, there were lots of systems issues and resource issues, but the issue of polysubstance abuse came up, which is a medical issue. And I don't know if you guys want to comment on that.
I don't know if you do, Adrian. I'm happy to start. I'd say polysubstance use or exposure for the infants can make it more challenging to care for infants with withdrawal for multiple reasons. The first is their withdrawal can be more unpredictable. And the second is often those are families that are potentially more challenging to engage. And I would just use this as an opportunity to continue to reinforce that when you're providing ESC, you do so by optimizing non-pharmacologic interventions to the extent that you can in your care setting and at your institution and for that specific baby. And so this might be an opportunity if the family's not involved or you're working to engage them to really lean into some of the other non-pharmacologic interventions you have.
Mina, take us away. Let's talk about the successes.
Adrian, did you want to chime in? I think, you've shown us beautifully the depth of the education and the standardization of care and the preparing the team for a culture change. And thinking of the flip side of that coin as well, engaging families. I don't know if you had some thoughts on that being a challenge and also the biggest reward of really having a full multidisciplinary team with families in this care approach.
I mean, I think you just stated it beautifully. It is a huge benefit. And I'm looking through the word cloud to see what words are coming up. I see empower in there, and I see parents in there, and support. And one of the biggest rewards of the ESC approach is that it is a shared care tool. It is not our staff evaluating a patient. It is a shared assessment between the staff and the parents about what's going on. And it walks you through a care pathway. How is the baby doing? What might we do next? What are potential options for the future? And gives everybody a shared mental model so it doesn't feel like there are surprises. And I think that's really important. And I think it's really helpful for both families and staff.
Beautiful. Thank you so much, Dr. Paul. And the time always goes so quickly. We're already at the top of the hour. I feel like we could chat for several more hours about this amazing body of work that the two of you have helped to lead and help change practice nationwide and across the world. So I'd like to extend heartfelt thanks to both of you for joining us today on Von Grand Rounds. And this is the survey that I had mentioned earlier. This is not the end. We hope to have, continued engagement with the community. So if there is interest at your hospital, your system, your state, please let us know where you're coming from, what the interest might be. There are questions on this survey that can help us learn about that and have a way to contact you, as well as an opportunity to get the 1 hour of continuing education credit for this session today. We'll post the video of this, and so anyone who's watching this within the 30 days also is able to answer the survey and get the credit. So we hope to hear from you and reach out over that. And we will also have 2 more sessions in the calendar year. In August, Roger and I will be back talking about evidence to practice oxygen in the NICU. And at the last quarter of the year, we'll have a session focused on the NICU environment. So those promise to be just as exciting as today's, and we hope to see you then. And for further engagement, as always, we have an ongoing collaborative, and you can let us know if you have interest in engaging even deeper with All Care is Brain Care, which care of the infant who is exposed to opiates absolutely falls within this realm of making sure that all the care we're providing in the neonatal units is focused on brain care. So let us know if you have deeper interest. And thank you. We will see you again.
Thanks for joining us.
Thank you.